Hello guys, welcome to my YouTube channel. I am Denmark Aranas, a fourth year medical clerk, and I basically provide informative videos to medical students. And also, I would like to give aspiring Filipino physicians an idea of what a medical student usually tackles in medical school. If you find these videos helpful, please don't forget to hit the like button and subscribe and click the notification bell to be updated of my videos, for I'll be posting new videos every week. This video is part of my approach series where I discuss the proper attack to a certain chief complaint. And this is basically a guide in giving the appropriate questions to ask in the history and point out certain PE maneuvers to consider. Please take note that diagnostic examinations and management plan are not part of this discussion in the approach series. So for today, our topic is the approach to weight loss. Weight loss is commonly associated with cancer because any type of cancer manifests as weight loss. However, weight loss can only be observed at the late stages of cancer. So, in this lecture, I would like to inform you of the early warning signs we must note of to detect cancer at its early stages. Aside from cancer, we also have to discuss various differentials you have to keep in mind when patients come to you with a chief complaint of weight loss. Here is the topic outline. First, we'll be defining what an involuntary weight loss is, and then I will give you the pivotal points in IWL, and lastly, we will go through the various differentials for weight loss, taking into account the history and PE. Okay. So what is involuntary or unintentional weight loss? It is defined as a loss of 10 pounds or 4.5 kilogram or greater than 5% of one's body weight over a 6-month period. It commonly manifests as loss of appetite or anorexia, loss of muscle mass or sarcopenia, cachexia, the combination of the two, sarcopenia and anorexia, and lastly, dehydration. IWL is a common chief complaint in the clinics, and we must consider the definition to confirm what the patient is experiencing. And here now are the pivotal points in our IWL. As a clinician, we have to document weight loss of the patient, ask the patient of their previous weight and compare it with the current weight, or if the patient observed changes in fitting of his or her clothes, becoming more loose. Next is ask about diarrhea or malabsorption symptoms. An important symptom would be steatorrhea, as you can see here. Steato means fat and rhea means flowing. Steatorrhea is actually excessive fat in the feces, and it is noted to be oily in characteristic. You should ask how many times does the patient flushes his or her stool because steatorrhea is hard to flush out of the toilet. Aside from that, you must also note for symptoms of vitamin, mineral, and nutrient deficiencies. And one thing you must consider is anemia, which should be observed by assessing if the patient has any pallor. And lastly, you have to elicit comprehensive history and detailed head-to-toe physical exam because we have to rule out cancer early on. That is a dreadful condition that should always be taken into consideration when patient comes in due to weight loss. Here I present to you the different colors of cancer awareness. Let us all acknowledge our cancer patients who are bravely fighting the disease. Let's now go to the differential diagnosis for weight loss. So here is a list of The differential categories of weight loss, by which the various conditions fall under. We have psychiatric disorders, malignant neoplasms, metabolic diseases, chronic inflammation or infections, and others. Let's start with psychiatric disorders. Under it would be depression and eating disorders. First is depression. Weight loss is a common manifestation of this disorder because of significantly poor appetite. In history taking, you have to ask the patient if over the past 2 weeks, have he or she felt either down, depressed, or hopeless, or if he or she had little interest or pleasure in doing things that she used to like before. Either of the two must be present in a depressed patient. A depressed mood, or this one, anhedonia. And according to the DSM-5 criteria for the diagnosis of major depressive disorder, there must be 5 or more symptoms listed here noted by the patient over the 2 weeks period. And also, these symptoms must have affected his or her functioning in either at home, school, or at work, and could have impaired her physically or socially. And during the interview, observe the patient's mood and behavior, which would hint you of the diagnosis. As for the physical exam, please be observant of the red flag of depression, which is self-harm. If the patient is wearing clothes inappropriate to the weather, that patient could be hiding something, like wearing a jacket or long sleeves despite the hot weather. Please inquire about suspicious wounds or scars of the patient, and please do assess the psychological state of your patient when you suspect a depressed patient. You could save someone's life by simply showing how much you care. Let's proceed now to eating disorders. We have bulimia and anorexia nervosa. For anorexia, please ask about the eating pattern of the patient and be wary of extreme eating restriction and ask about the patient's fear of gaining weight. Assess the patient's perception of their body image. As for bulimia, ask if the patient has a recurrent cycle of binge eating followed by purging, and if the patient is doing forced vomiting, fasting, excessive exercise, abuse of laxatives or diuretics. And a common denominator for anorexia and bulimia would be the fear of gaining weight and a negative body image. Despite attaining normal weight, they wanted to lose more. For the physical exam, the anorexic and bulimic patients have the characteristic skin and bones physique, as you can see here in the picture. We now move on to malignant neoplasm. A general premise that you have to keep in mind is all cancers manifest weight loss at the late stages. And here I present to you the early warning signs of cancer, which could easily remember by the mnemonic caution up. A dictum that you must note of is that the earlier we detect cancer, the better the prognosis would be. So it is important to know these warning signs you have to check in every patient that are predisposed and have risk factors for cancer. So C, change in bowel or bladder movement. A lesion that does not heal. U, unusual bleeding or discharge. C. Thickening or lump, as could be seen in breast cancer or testicular cancer. I. Indigestion or difficulty of swallowing, as you could see in esophageal cancer. Obvious changes in wart or mole, as you can see in skin cancers. Nagging cough or persistent hoarseness, as would be presented in lung cancer. And here is the unexplained weight loss, U, and P, pernicious anemia. There are a lot of maneuvers we could do to detect cancer using PE. As you can see here, clinical breast exam for breast cancer, digital rectal exam for rectal, anal, or prostate cancers, speculum and pelvic examination for cervical, vaginal, or uterine cancers. Next would be metabolic diseases. And here's a list of the disorders under it. We have hyperthyroidism, diabetes, pheochromocytoma, and adrenal insufficiency. Let's start with hyperthyroidism. Here is an infographic about it. As for history, ask if the patient has easy fatigability and weakness, palpitations, nervousness, difficulty of sleeping, and profuse sweating. For PE, check for hair loss, thyroid enlargement, protrusion of the eyes or exophthalmos, tachycardia, and hypertension. As for diabetes, you have to note that at the late stages, there the patient would experience unexplained weight loss. And early on, they may have weight gain and then later the weight loss. In the history, take note of the 3 P's of diabetes: polyuria or frequent urination, polydipsia or increased thirst, and polyphagia or increased appetite. As for the PE, check for the sensation of the extremities to avoid the complication of diabetes, which is diabetic foot, from poor healing of wounds incurred due to the poor sensation. Next is pheochromocytoma, which is a condition related to increased catecholamines that are responsible to its manifestations. History is very important here, and a hallmark of this disease is hypertension. As for adrenal insufficiency or Addison's disease, elderly females are more predisposed to having it. And in the history, take note of weakness and GI disturbances. In the PE, take note of the bronze pigmentation of the skin, changes in the distribution of body hair, and most importantly, postural hypotension. We now go to the next category, which is chronic inflammation or infection. We have here bacterial overgrowth, tuberculosis, HIV, intestinal parasitism, and COPD. For bacterial overgrowth, take note of the following in the history: previous history of GI surgery, long-standing diarrhea, bloating, weight loss, and inflammatory bowel disease. As for TB, classic presentation would be chronic productive cough, night sweats, low-grade fever, usually in the afternoon, and chest pain. At the late stages, patients may have hemoptysis or blood streak phlegm. PE would reveal significant chest and lungs findings like asymmetrical chest wall expansion, retractions, decreased breath sounds, and among others. Based on recent studies, tuberculosis are seen more in HIV-infected patients, owing to the fact that these patients have impaired immune system. They say that there seems to be co-infection between the two. So it is very important to test for TB those HIV patients who have chronic cough. Take note of that. Here are the main symptoms of acute HIV infection. It presents with non-specific signs and symptoms like fever, malaise, headache, and rashes. So what is very important to note in the history taking is the sexual history. Inquire about the risk factors of the patient in acquiring HIV infection, and that would be having multiple sexual partners and unprotected sex. Next would be intestinal parasitism. Patient would commonly present with diarrhea, nausea or vomiting, abdominal pain, and confirmatory presentation would be passing out a worm in the stool. Last, under chronic inflammation would be COPD, which is due to chronic airflow limitation. And under it would be emphysema and chronic bronchitis. Emphysema typically presents as cachectic patients. Here are the signs and symptoms you have to take note of: chronic cough and easy fatigability due to labored breathing or dyspnea. With BE, you should note patients' first lip breathing, use of accessory muscles, barrel chest, wheezing, and also digital clubbing. Lastly would be the others. Smoking and illicit drug use like marijuana, cocaine, amphetamines causes weight loss due to its appetite suppressant effects. Aside from that, certain diabetic drugs too causes weight loss, such as metformin and SGL2 inhibitors that end in gliflozin. Age-related disorders like could cause involuntary weight loss. This could be due to ill-fitting dentures that result to mouth ulcers, and predominant taste among elderly would be bitter, and this could lead to loss of appetite. And lastly, financial deprivation, which is a sad reality for most Filipinos. How socioeconomic factors impact health is great for those patients who are marginalized and experience poverty. Well, that's it. I would like to end my discussion with a quote. Despite personal or physical limitations, one must never lose faith and confidence in oneself, as well as courage in facing the adversities of life. For our cancer patients, we admire your strength in fighting the battle against the disease. Please remember that we are always here to support you along the way, and we believe that you can come out of this victorious. And at the times of difficulties, please do not lose faith and confidence in you. You have been through so much, showing how much courage you have. Do not forget also your faith in our Lord. God will always comfort you along the way. Thank you for fighting. For medical students, though we may have times of failure and shortcomings due to our personal or physical limitations, let us not be disheartened by this. We must always have faith and confidence in ourselves that we are doing our best to be the best physician we could be. You have come a long way already, and that shows how much courage you have in you. There are so many people around you who believe in you. Make sure you are one of them in this journey towards that MD. Thank you for listening. I hope you learned a lot and have a good day. Thank you.